Okay. We'll review some stuff, but then we're gonna hit the meat of the subject. 1 second. All right. Chemical neurotransmission. Any questions with this? So a lot of mood and anxiety has very similar treatments. Sorry, I'm sorry, these are my dogs barking. But increasing serotonin and increasing norepinephrine, what does it do in the brain? Do you guys remember from your reading? Why is it important to increase those two neurotransmitters? What does it do? What do you think it does? It downregulates your amygdala, right? So we're talking about anxiety disorders today. So in anxiety disorders, your amygdala is actually hyperfiring, right? So your amygdala is the emotional part of your brain, which is hyperactive, right? So there is a link between your amygdala and your hippocampus. Why is that important? What does your hippocampus do?
Memory.
Very good, right? So people who are, I don't know, have a phobia, who are afraid of dogs or afraid of cats or whatever, that bad experience is going to get ingrained in their hippocampus, right? And that connection to the amygdala gets a little bit stronger. So every time they see that stressful stimuli or that painful memory, what happens? It links back to the amygdala, and then your amygdala will trigger your locus coeruleus, right? Increased norepinephrine, which will trigger your fight or flight response. Does that make sense? Right? So see that connection there? So hippocampus is your memory. Any bad memories or anything that's triggering will affect your amygdala. So you want to find ways to dampen down the amygdala. One way to dampen down the amygdala is actually increasing serotonin, right? Increasing serotonin has an inhibitory effect in the amygdala. So when you give someone an SSRI like Zoloft, which is FDA approved for PTSD, it's going to temper that down, right? Norepinephrine also is implicated. So what happens is initially you increase norepinephrine, people do get a little, they get a little bit of anxiety in the beginning, right? That's because what happens to the receptor when you innervate it with norepinephrine? It's going to cause a fight or flight response, right? Norepinephrine, fight or flight. So it is going to cause tachycardia. It might cause hypertension. It will increase, sweating. People might be diaphoresis, right? They might have tunnel vision, right? Because you're going to have vasoconstriction, or you're also going to have pinpoint pupils, right? Because you want to focus on whatever's dangerous. But over time, what happens when that receptor for norepinephrine, let's say your beta receptor, right, gets innervated? It's going to downregulate, right? Once that beta receptor downregulates from norepinephrine, things tend to get better, right? That's why it takes time. That's why initially, a technique I like to use is when I give people an SSRI or SNRI for anxiety, I might give them a temporary dose of benzos, right? If they don't have a substance use disorder or they don't abuse alcohol. And that's going to be temporary in the very beginning while their neurons are adapting to that medication, and they can take it PRN as needed, right? I do like to use, we're going to talk about benzos today, but I do like to use lorazepam and I like to use Klonopin. Xanax, very rarely. What's the problem with Xanax? Why is it?
Short half-life.
Or
Short half.
half-life, and then it's like a rebound anxiety
Yes,
after it wears off.
yeah. So Xanax only works about 1 or 2 hours usually, and it's usually for circumstances like flying, right? Or people need to get blood work because they're afraid of needles. I'll give them Xanax then. But for long term, it's not going to give you coverage for the whole day. And it's also very is it lipophilic or lipophobic? What do you think? Lipo what?
Hypophilic.
Lipophilic. That's why it crosses the blood-brain barrier, right? That's why it works faster and it hits pretty strongly.
And it leaves the bloodstream quicker or something like that.
It will, but it also crosses the
Brain, but
blood-brain
then
barrier. Yeah. Remember, that was a question in the exam. The brain is a biphospholipid bilayer, right? It's two lipids with water in the middle, right? So you need to cross those two lipid bilayers for it to get through. So a lot of our meds they have to be lipophilic, or they would never work. All right. Some are more lipophilic than others. Okay. Slide. Once again, type of neurotransmission, anterograde is classical neurotransmission, retrograde is going back. And volume neurotransmission, we're going to touch with that during spring break when we talk about stimulants or medications for ADHD. Targets of neurotransmitters, all right? So if we're using SSRIs, SNRIs, just know that's 12 transmembrane pumps, right? So it's just called 12 because the protein goes in and out of the membrane 12 times, all right? G protein, we're going to talk a little bit about that also. These are the receptors for it. So D2, 5-HT2A, 5-HT2C, 5-HT1A, 5-HT7, those are just some. MAOIs, we don't really use in anxiety, but that was important for depression. Ligand, we do use for anxiety, all right? And also some for depression. And voltage gated we use for anxiety also, all right? Those could be like the mood stabilizers sometimes. So those have anti-anxiety properties as well. Any questions?
What type of mood stabilizer would you use for anxiety?
Depakote has anti-anxiety properties as well. So if someone has like bipolar disorder and has a lot of anxious distress with it, sometimes Depakote, since it works on what? What does it work on?
The voltage gate, the sodium channels, right?
That too, but it also works on GABA. Remember we talked about GABA?
Yeah.
GABA is the mechanism of action for benzos, right? And Depakote works on GABA as well, increases GABA. Probably not as much as the benzodiazepine, but it is going to help, temper down your neurotransmitters, all right? Upregulation, downregulation, that's a very important concept. Don't forget about that, right? Upregulation is when you're blocking the receptor. So you're giving someone an antagonist of whatever neurotransmitter. Those receptors are going to upregulate to compensate, all right? The opposite, if you innervate something too much, you give someone an agonist, it's going to protect itself by downregulating, right? To protect itself from overstimulation. Same thing, sensitization. If you're blocking something too much, right, the receptors that are coming up are actually going to become very sensitive because you want some more stimulation. And if you stimulate something too much, it's going to desensitize, all right? Because it's going to try to relieve too much stimulation because that can lead to excitotoxicity, right? Excitotoxicity can be dangerous also. Agonist spectrum, right? Remember agonists, it's like your body's natural neurotransmitter. Partial agonist is a stabilizer. It can work both ways. It can work as an antagonist if there's too much stimulation, or it can work as a agonist if there's not enough stimulation, right? Antagonist blocks, right? But there's still going to be intrinsic activity. Inverse agonist, I know in the test question, it says the opposite effect. That is true. And there's no intrinsic activity, okay? There's only a few inverse agonists in psychiatry, right? Clozapine is one, and the other one is pimavanserin, which is a 5-HT2A inverse agonist. We'll talk about that later when we talk about schizophrenia. Pharmacokinetics versus pharmacodynamics, make sure you know that. Remember absorption, distribution, metabolism, excretion. Majority of the meds are metabolized in the liver, and a lot of the majority of the meds are excreted by the kidney. So kidney functioning is very important, all right? What is the most specific test that we look for checking kidney functioning? What is it?
Filtration.
Creatinine.
Creatinine.
It's actually GFR. GFR. Yeah. All right. BO and creatinine will give you an idea, but the most specific one that we use is GFR, especially for lithium. Once GFR starts to go below 50, you have to stop the medication. All right. CYP drug interactions, no inhibitors. Inhibitors will increase the substrates that are metabolized by that same enzyme. Inducers are going to reduce the amount of medication that's metabolized by those substrates, all right? So you give someone a 3A4 inhibitor, any other medications they're taking that need 3A4 for it to metabolize are going to go up, right? You give someone a 3A4 inducer, any medications that need 3A4 to be metabolized are going to be eaten up, and there's going to be no effect, all right? A lot of times if you're prescribing a medication to a patient and they say they're taking it, right, and you know they're taking it, but there's no effect, there's no side effects, they could be a rapid metabolizer, right? They could just be genetically a very fast metabolizer of 3A4 or 2D6. You could do genetic testing or you could do blood levels. It's really up to you. And you'll know that maybe you might have to increase the dose of the medication to override that induction, or you can switch it to another medication that does the same thing that's not metabolized by that enzyme. Does that make sense? So if someone is a 2D6 fast metabolizer, so every medication that I give them, let's say for psychosis, gets eaten up too fast, you have an option. You can either give them an increased dose of that medication, right, to override the 2D6 induction, or you can give them another medication that is a substrate of another enzyme, so it doesn't interfere with that pathway, like 3A4. Does that make sense? Okay.
Can you explain that again?
Okay, I give you a medication, right? Let's say it's metabolized by 2D6. Let's say like Abilify. And then it's not working. You're taking it every day. We get all the way up to 20 milligrams, and there's no side effects, but you're also still having psychosis, right? It's antipsychotic medication. I can assume you're a fast metabolizer, right? A rapid metabolizer or a fast metabolizer by doing a level of Abilify level, or I can just keep pushing the dose up and there's no response, right? So if that's the case, or I can do genetic testing is another option, but it takes a while. Or I can switch you to another medication that's a 3A4 substrate, so we don't have to, we don't have to use your 2D6 pathway for that medication. Does that make sense? So you can use an alternate pathway. So there's medications that do the same thing, but are metabolized by different CYP enzymes. So it doesn't mean you have to change class of meds. You can just use the same class of med, but use another med from a different substrate. Does that make sense? right? So 2d6 is 3A4. If it's 3A4 med that's being eaten up too fast, switch to 2d6 medication, all right? Sometimes it's not that easy because some meds are metabolized by 2 enzymes, so maybe you might not have that option. It really depends on the medication, okay? Pharmacodynamics, how does it work on your body, all right? So let's say for anxiety, is it a GABA drug, GABAergic medication? It's going to increase GABA, right? Is it a serotonergic medication? Is it increase serotonin? Is it a norepinephrine medication? Increase norepinephrine? Or is it a little bit of both? It really depends, all right? Okay, again, this is the pathway. Just understand like how it generally works. Okay, this is the dopamine pathway. So we're going to talk about dopamine pathway a lot today because we're talking about psychosis. So dopamine pathway for psychosis is actually increased dopamine in the mesolimbic pathway. So we're going to go to that so you guys can see. Actually, we'll go to that after. Let's stay in anxiety. I'm sorry. We'll stay in anxiety for now. All right. I talked about this before. Amygdala is part of the fear circuit. So hyperfiring amygdala means that people can have phobias. They can have general anxiety disorder. They can have social anxiety. What's the difference between general anxiety disorder and social anxiety disorder? What's the difference?
General anxiety is like kind of an unknown source of anxiety
Okay,
a lot of
good.
the time.
Okay, good. And social anxiety is pretty much what it says, right? They're afraid of social situations. And they can't
Social
go to the
situation.
supermarket, they can't take public transportation, they feel like people are judging them, staring at them, and they get very nervous and their fight or flight goes up, right? So these are just some of the pathways, right? These are just parts of the brain. PBN, parabrachial nucleus, that has to do with breathing. So someone who has a hyperactive parabrachial nucleus, that's PBN, para, P-A-R-A, brachial, B-R-A-C-H-A-I-A-L, parabrachial nucleus is the part of your brain that will increase your ventilation. So people will start having increased breathing, which will increase your heart rate, which can lead to a panic attack, all right? Locus coeruleus or locus coerulean is the cell body that increases norepinephrine, all right? So you have hyperactive locus coeruleus, you're going to have too much norepinephrine, all right? PAG stands for para-acridal gray, all right? Hippocampus, we talked about it. Overall, so just know, I'm not going to ask you specifically the brain regions, but just know that, you know, these are just some of the pathways, all right? The worry loop is the CSTC, corticostriatal thalamal cortex, all right? So it goes from your cortex, which is your cerebral cortex, to your striatum, which is your motor pathway, right? So people might worry and then they'll start having compulsions, or they might worry and they start walk away from what's worrying them, right? So your striatum is affected too because you're moving. Your thalamo, which is your thalamus, which is the relay station. That's why everything goes through that, has to go through your thalamus, back to your cortex. All right. So that pathway is hyperactive when people are worried, right? That could be OCD. That could also be, you know, other obsessions. Any questions about that? So fear response, it's amygdala related. All right. Someone is having obsessive thoughts or worry, that is your corticostriatal thalamocortical cortex, CSTC, corticostriatal thalamocortical cortex. Any questions? Okay.
So with the worry, it originates in the prefrontal cortex and then it affects all the other.
Yeah, so it's a loop that if you look in the style book, it does a pretty good job showing.
Yeah, I was reading it last night.
Yeah, kind of goes back and forth. Yeah.
Okay.
Right. So a lot of our medications kind of stop that loop. Okay. Okay. So these are some of the treatments. SSRIs, SNRIs, right? We talked about this in depression. They're good medications, they're good treatments because number one, they're not addictive, but they can cause sexual dysfunction, all right? GI side effects, especially from serotonergic medications, all right? Because a lot of your serotonin is in the chromaffin cells of your stomach, right? So that's why a lot of people get diarrhea, nausea, sometimes constipation. So what you can do is you can tell them, take the medications after meals, right? So there's food to coat the stomach and it's a little bit less, okay? Possible triggering of mania. So let's say you don't do a good job of assessing if there was family history of mania or past hypomanic manic episodes that can trigger a manic episode. So just be careful. Okay. Bleeding risk, because you also need serotonin for clotting. So, you know, if there's dysregulation of serotonin, people might bleed a lot. That's why sometimes when it's combined with other anticoagulants, you have to warn them about that. Okay. SNRIs especially can cause spontaneous liver injury, so make sure that you actually check ALT, AST for any inflammation, and just, you know, sporadically, I would say at least once a year, do a liver enzyme, okay? If they're on SNRIs, okay? Once again, SSRIs, clotting issues, GI side effects, induction of mania. Another important one is, suicidal ideality, because there's that black box warning. It can cause that, especially with young teens and young adults. So be careful. You make sure you ask about that. SNRIs, same side effects as SSRIs, but spontaneous liver injury. Okay, so make sure you check about that. Another one is hyponatremia. It's not on here, but it happens as well. It's kind of rare, but it can happen. Hyponatremia is low sodium. All right. So what it does is a lot of the medications, they inhibit your body's ADH. So your body will actually have too much ADH, which is called antidiuretic hormone. So what happens when you flood your body with ADH? You're going to retain water and your sodium levels are going to go down in proportion to water, right? Which can cause hyponatremia. Early signs of hyponatremia can be confusion. Long-term hyponatremia can lead to seizures, all right? Convulsions, so be careful about that. Okay. Alpha-2 delta-1 ligands are actually your Lyrica and gabapentin. So in Europe, Lyrica is actually is approved, not FDA, but whatever their FDA is approved for GAD. But we use it off-label here in America. Gabapentin is also used off-label for GAD. All right, you do see it sometimes, but it's off-label. Just know that. Okay, alpha-2 delta-1 ligands are actually connected to calcium channels. All right, so when you block that receptor, it stops the efflux of calcium going inside the cell, and what happens? It doesn't secrete neurotransmitters, right? So it kind of dulls down your hyper response. So it'll actually dull down your anxiety. All right, any questions with that? Okay, benzodiazepines. So benzodiazepines, what they do is they increase the opening of chloride channels. Chloride are what? Are they positive or negative?
Negative.
They're negative, right? So when you make a cell more negative, you're actually decreasing the firing of it, right? Because it hyperpolarizes the cell. When a cell becomes more negative, it's less likely to fire. That's why it helps with seizures. That also helps with anxiety, also helps with mood. Okay, so those are your benzodiazepines. The problem is obviously, tolerance, dependence, if they drink alcohol, ataxia, confusion, retrograde amnesia. That's why it's used, for date rape. So be careful with that. People will forget what happened. Confusion. And just know there are some studies that show that maybe long-term benzodiazepine use could predispose people to Alzheimer's. All right, it's inconclusive, but you don't really want to give it to older geriatric patients unless you really need to. Plus dangers of fall risk, right? Anticholinergics, we mentioned this last time, constipation, urinary retention, confusion, blurred vision, and narrow angle glaucoma. Right? So if someone has narrow angle glaucoma, you should not give them anticholinergic medications. Okay. Okay, these are just a list of some benzos. Just kind of know the general half-life, which ones, are long half-life, which ones are short half-life, right? Everyone knows Xanax, works rapidly, but has a short half-life, so we use it a lot for situations like flights or like medical appointments. Okay, we tend to use Klonopin a lot because it tends to be safer because it's longer, gives longer coverage. Okay, it's not as lipophilic as the other medications. Lorazepam we use also a lot because it has no active metabolites and it's not metabolized in the liver. So it's outside the liver. So people who have liver injuries or impaired liver functioning, they tend to use lorazepam a lot more. And in child psychiatry, lorazepam is the only medication we use in kids because it's the only medication that's really been studied in kids. So a kid needs a benzo, which is rare, you would use lorazepam. Okay, lorazepam is also used for catatonia. That's the only evidence-based medications for catatonia, which we'll talk about, in a few minutes when we talk about schizophrenia. Any questions so far? All right. Chlordiazepoxide is Librium. Okay, if you guys don't know what that is. Diazepam is Valium. You still see that in ERs. So I want you guys to memorize the generic names, but also know what the brand names are. Because some patients might come in and they might mention some names of meds and you don't know, but you need to know generic and the brand. Okay. Temazepam is used for sleep. Clonazepam is Klonopin, like I mentioned, has a pretty long half-life, so I like to use that a lot. Low dose. Any questions?
Can you just explain the negative chloride part again?
Yes. So GABA works on benzodiazepines work on the GABA receptor as PAMs, positive allosteric modulators. Someone send me something in the chat. I can't see it. 1 second. Oh, okay. Sorry about that. So what it does is, since it's a positive allosteric modulator, it doesn't work directly on the channel itself. It works on like a modulating side of it, which actually increases the amount of chloride going inside. So normally when GABA touches that receptor, chloride will go inside, right? When chloride goes inside the cell, it tends to make the cell negative, right? That's why it repolarizes the cell, okay? The thing is, since it's a positive allosteric modulator, you still need GABA to work at the same time. You need both at the same time to open that chloride channel. So that's why it's not working directly on GABA, it's working on that channel. So someone still needs to have GABA attaching to that receptor for the chloride to go inside. Does that make sense? It's not a GABA agonist. A GABA agonist is actually going to bind to the GABA channel and cause chloride to go inside, right? A positive allosteric modulator, like a benzodiazepine, will bind to that site on the side of it, but you still need GABA to get in the receptor itself, which is your body's natural GABA to open that chloride channel. Does that make sense? Okay. Okay, this is the dopamine pathway that we talked about. Okay. So know the mesolimbic, especially when you talk about schizophrenia, because the mesolimbic area is proposed to explain the reason why patients have positive symptoms, right? What are positive symptoms? Positive are symptoms that are extra, right? Extra sensory responses. So it could be extra visual, which could be visual hallucinations, right? Extra auditory, which could be auditory hallucinations, which normally like 70% of hallucinations, positive symptoms are actually auditory, all right? Maybe 30% are visual and the 10% will be tactile, which is feeling like they're being touched, right? Or olfactory, which is even more rare, which is they smell something that, it's not there, okay? A lot of times if someone has olfactory hallucinations, I want to rule out organic causes first, right? God forbid a tumor or substance use. Substance use is more common with tactile hallucinations, right? Where they feel like they have bugs crawling on them. That could be from amphetamine use disorder or stimulant use disorder. Okay, so be careful about that. And visual hallucinations also tend to be organic also, right? It could be a seizure. So if someone has an occipital lobe seizure, what do you think they're going to experience? What kind of symptom? Occipital lobe.
Visual.
Very
Their
good, right?
vision.
Visual cortex, very good. Someone who has a temporal lobe seizure would experience what?
Sound.
Auditory, very good, right? It's linked to your ears. So you want to rule out seizures. So you can order EEG, have them see a neurologist. It's really up to you, and rule out any other medical causes before you give them antipsychotic medication. All right, because if not, that's a lawsuit. A lot of our medications do lead you. So let's say, for instance, you don't rule out a medical cause, right? And you give someone an antipsychotic medication, and they start having even stronger hallucinations. Remember, our meds tend to lower the seizure threshold. So if they start having more seizures, they're gonna have worse than psychosis. Then that's not good, right? It can cause more injury, and that's a lawsuit. Okay, so be careful. Striatum, that's movement disorder. So ideally, you want a medication that can decrease dopamine in the mesolimbic area, right? Which is the connection from the VTA to nucleus accumbens, right? Increase dopamine in the mesocortical area, because that's for negative symptoms, right? You want to increase focus, and you don't want it to touch the nigrostriatal area or the tuberoinfundibular area, right? Because that's not going to affect prolactin. But unfortunately, our medications, when we take them, they go in our mouth and we swallow them, they disperse, right? They diffuse into all parts of your brain. So unfortunately, that's why side effects happen, all right? And usually you need about 80% of dopamine blockade, or 60 to 80% on average dopamine blockade to get very good antipsychotic effect, all right? But the problem is blocking 80% of your dopamine receptors in your nigrostriatal area is also the threshold for causing EPS. So what happens if someone needs 80% dopamine blockade to help with their psychosis? They're also prone to EPS, because remember, it might block 80% of the mesolimbic area, stop psychosis, but it also might block 80% in the nigrostriatal area and cause movement disorders, right? So unfortunately, we need to balance it out. So you can try reducing the dose of the medication, but their symptoms of psychosis might come back, right? Or you can add a medication like cogentin or benztropine, which works by what pathway? What does it do? It's an what?
Cholinergic.
Very good, anticholinergic. All right. Can someone explain to me why an anticholinergic medication is going to help in movement disorders? What does it say in the book? There's an inverse relationship between dopamine and acetylcholine in the nigrostriatal area. When you block dopamine, your body will actually increase acetylcholine, which can lead to spasms, spasticity. It can lead to Parkinsonism, tremors, imbalance, gait, right? Shuffling gait. So what you need to do to balance that out is, if you're blocking dopamine in the nigrostriatal area and the acetylcholine gets too high, you need to give them an anticholinergic medication to kind of balance it out. Think of a seesaw, all right? You're blocking dopamine because you want the psychosis to get better. Acetylcholine starts to reflexively start going up, all right? If they're the unlucky ones that need 80% dopamine blockade and you know, of antipsychotic, they're also at higher risk of developing EPS if you give them a dopamine blocker. So you need to give them anticholinergic medications like benztropine or diphenhydramine like Benadryl. Okay. Any questions with that? Does that make sense? So the anticholinergic is going to balance out the innervation of the acetylcholine. So it's not going to cause those side effects, right? Cogwheeling. Cogwheeling means that you bend the arm and it moves like a cogwheel, right? It's not smooth. So see, notice my arm is moving smoothly right now. That means my nigrostriatal area has just enough dopamine, right? Once patients are on dopamine blockers, their movements might be not as smooth, right? You try to bend their arm, you might even like catatonia, it might be waxy, all right? So the movement's not going to be as coordinated, right? Coordinated movement, okay? Same thing happens in the mesocortical area, right? Because you're blocking dopamine in the mesolimbic area. What happens when you block dopamine in the frontal cortex? People have negative symptoms, worse than negative symptoms. They might have poor concentration. They might feel flat, inability to feel pleasure, right? They might be confused. And sometimes that could be misinterpreted as ADHD, but it's not because they're on a dopamine blocker. All right. So sometimes what you can do is you can give them a 5-HT2A antagonist, right, which will actually increase dopamine in the frontal lobe and increase dopamine as well in the nigrostriatal area. So you have two options. You can give anticholinergic medications to help with EPS, right, because that will balance out the imbalance of acetylcholine and dopamine. Or you can give them a 5-HT2A antagonist, which will increase dopamine in the frontal lobe and also increase dopamine in the nigrostriatal area. Does that make sense? And the tuberoinfundibular also balance out prolactin as well. Any questions? It's a simple slide, but there's a lot of concepts here. So no, mesolimbic area is implicated in positive symptoms of schizophrenia. You need to give someone a D2 blocker in order to balance that out, okay? If they need a threshold of 80% dopamine blockade, then that means that there's a high risk of them developing EPS. Therefore, you have to give them anticholinergic medication to balance out that hyperfiring acetylcholine, right? Benztropine, diphenhydramine is another one, okay? Those are the two main ones that we use. Sometimes people also use amantadine, Symmetrol. You guys know what that is? Have you heard about that? It's used in Parkinson's. It increases dopamine too. We can do that also. The only risk about Symmetrol is that it can worsen psychosis because it's increasing dopamine a little bit too much. Or it can increase compulsive behaviors like gambling or sexual promiscuous behaviors. I've seen that as well. So be careful with amantadine.
How about with Ingrezza? Because that's more for just TD, right?
Yes. So Ingrezza will actually worsen EPS. It'll help TD, but it'll worsen EPS. Yeah, that's actually a side effect of Ingrezza, valbenazine. Gotta be careful with that. We'll talk about that when we talk about side effects. Antipsychotics, you have two types. You have typicals and you have atypicals. All right, typicals are the first generation antipsychotics. Atypicals are second generation or newer antipsychotics. All right. Just from a history standpoint, the first antipsychotic was created in 1952, chlorpromazine, Thorazine. All right, it was created by accident. It was actually a surgeon who was trying to find a medication to help with surgeries, and he was trying to develop an anesthetic. But he realized that when he gave this anesthetic to patients who had schizophrenia or psychosis, their psychosis got better. So that's when he put two and two together. All right. So chlorpromazine was the first anesthetic, followed a little bit shortly by clozapine, which is the first atypical antipsychotic. All right, which we use to treat treatment-resistant schizophrenia. All right. Some example of typical antipsychotics: chlorpromazine, haloperidol, fluphenazine, prolixin. All right. Those are the two. Those are the three main ones that we still see used a lot. There's a bunch of other ones too, but we don't really see them as much anymore. Atypicals are aripiprazole, Abilify, right, which is a partial agonist, olanzapine, Zyprexa, lorazepam, Latuda, Vraylar, cariprazine. There's just so many atypicals now. But just know, typicals tend to only block dopamine receptors very strongly, so people are more risk for developing extrapyramidal symptoms of dystonia, Parkinsonism, all right? So spasms, stiffness of the neck, that really happens with very strong D2 blockade. Atypical antipsychotics, and they tend to have more mechanisms they tend to cause more metabolic side effects. All right. So unfortunately, it's pick your poison. All right. What's more important to you, gaining weight or having, motor side effects? And your job is just to educate the patients, which one they're more, comfortable tolerating. I wish I can give them medication where that doesn't have any of those, but some patients tend to have no weight gain or atypicals. I've seen that too, right? Because genetics plays a role and also lifestyle. If someone's an athlete and they're running a lot and they're eating well, you might give them atypical, they might not gain any weight, right? So it's really up to your patient, their patient profile. Do they have a history of diabetes, their family history of diabetes, right? Do they have a hard time eating healthy food? Then I will probably stay away from atypical antipsychotics, right? Or is it a patient who's tried typical in the past and has had really bad stiffness of their joints? Then maybe the second round you'll try atypicals with them. Does it make sense? Okay. D2 antagonism, like I said, is helpful for psychosis, aggression, and also mania. 5-HT2A antagonism is helpful in mitigating side effects of drug-induced negative symptoms or side effects of, EPS in the nigrostriatal area. D2 partial agonists tend to be the most tolerated, better tolerated, but the only problem with them is they're not very strong antipsychotics. So how I practice usually is if someone comes to me for their first episode of psychosis, I'll try aripiprazole first, right? Because aripiprazole has been out for a long time. It's a fairly cheap medication, has a lot of studies. It's also FDA approved in children, very young age. So it is a good medication, but the only problem with aripiprazole is that you can only block 75% of dopamine blockade, right? At its highest dose, once you oversaturate that receptor, you're only going to get 75% dopamine blockade at max dose of aripiprazole, let's say 30 milligrams, all right? What if it's that patient that I was talking about that needs 80% of the dopamine receptors blocked for psychosis control? Abilify would be out of the picture. It's not going to help. It's not going to work for them, right? So if you want to go up, step-by-step approach and try to challenge them with different medications, because we can't really do blood tests or do any brain scans to see how much dopamine blockade a patient needs for relief of psychosis. I would usually try a partial agonist first, right? Like aripiprazole. And if they fail on it and maximize the dose, and I know they're taking it, and I can even do a blood level of aripiprazole, right? Which is 11 times the daily dose. So if someone's on 10 milligrams of aripiprazole, and I know it's 11 times the daily dose, what would their aripiprazole level be if it hits steady state and I do a blood level? What is it? What's 11 times 10?
110.
Very good. 110 nanograms per ml. All right. So if you look at the when you do a lab for aripiprazole, I'll just use that as an example. The lab will say minimum recommended would be 110 and maximum would be 330. All right. That corresponds to Abilify dosing of 10 milligrams to 30 milligrams. Does that make sense? Because the dosing goes with the level. Okay, 11 times the level.
Can you repeat that? Can you repeat that besides like the 10 times 11, the 11 times of the 10 milligrams, you said something afterwards, the 110 to 300.
Yeah, so when you look at the values for the lab, it'll usually give you a parentheses of what the recommended values are or what the normal values tend to be, even though that's not always accurate. It'll say 110 to 330, which makes sense because the recommended dosing of Abilify usually for psychosis is between 10 milligrams and 30 milligrams, right? Does
That makes sense. Yes, thank you.
Right. The good thing about D2 partial agonists is that they tend to have less metabolic side effects usually. I'm just saying usually, but with kids, they tend to be sensitive to the weight gain. So when I prescribe Abilify to kids, I usually educate the patients on, healthy diet and exercise because kids are more sensitive to that. Okay, kids tend to also have more lipids, right? Their distribution of lipids tends to be more, so the meds tend to stay more in their system, right? Because a lot of the meds are lipophilic. They love fats. Meds tend to stay in the lipids faster. Kids are more prone to side effects. All right. D2 partial agonists also tend to have less prolactin elevations. So if someone has a history of, say, a female has a history of hyperprolactinemia and lost her period, or a male has a history of developing sexual dysfunction with medications, I would probably try to use a partial agonist. All right. Now, the challenging part is you're balancing tolerability, right? Tolerability equals side effects versus efficacy, which is effectiveness. Sometimes you can find a good balance and patients will be on a medication that is tolerable, right? They don't have side effects from it, but it's also effective at the same time. Sometimes you can't find that balance. So it's really working with your patient to see, how they're doing in the medication, all right? And also another risk, EPS versus metabolic burden, all right? Does that make sense? Okay. So in a general sense, atypical tends to cause more metabolic symptoms. Sometimes we prescribe them metformin and we counsel them on healthy diet and exercise. All right, those are some interventions you can do. Okay, metformin, I usually start at 500 milligrams once a day. Once I tolerate it for a month, and I go to 500 milligrams BID. Then from there, I go to 1500, and the max goal is actually 2000 milligrams a day, which is ideally 1000 milligrams BID. That's the goal. All right, I tell the patients that because that's what the studies show. The studies show that to mitigate metabolic side effects of atypical antipsychotics is 2000 milligrams of metformin a day. All right, so push it up. I see a lot of patients where they're prescribed metformin, but it's like 500 milligrams a day. That's not going to be enough. You really want to push it up. All right. Know that long-term metformin use can actually deplete B12 and folate levels. So this can happen too, right? Someone comes to your clinic, you put them on, let's say, olanzapine, because that's one of the most weight-gaining medications. Their psychosis is better. They're taking the metformin, 2000 milligrams a day. All of a sudden, they develop really, really bad depression. I would recommend ordering a B12 folate level, right? Especially if they're vegan, right? Vegans don't eat meats, they don't eat eggs. They're more risk of developing those deficiencies. I would do a level, and they would need to supplement it. All right, because remember, B12 and folate are needed to make your neurotransmitters, especially serotonin and norepinephrine. So what happens if you don't have enough of those neurotransmitters? There's no gas in the car, right? You have an engine, there's no gas. You can't make any more neurotransmitters because you have B12 and folate deficiency related to long-term metformin use. Okay? Any questions?
As a psych NP, is there like any roadblocks to prescribing metformin?
No. I use
Okay.
metformin pretty regularly, and I yell at a lot of primary care doctors for not using it.
Okay.
Because they'll say, whoa, why are you being put by Psych NP on metformin? You're not diabetic.
Right. Yeah.
It's our job to educate them that and show them the studies that this is evidence-based, that the patients will probably gain weight, especially on olanzapine. So it's our job to educate the primary care providers who aren't aware of this, all right? And it'll happen on a regular basis. I do it at least, I don't know, every 2 months. All right, because it's not going to be enough. Healthy diet and exercise is not going to be enough. And remember, once you start metformin, after someone's gained 30 pounds, they're not going to lose 30 pounds. The best evidence is to start it right away. So as soon as they start the olanzapine, you probably should start metformin right away. I mean, a patient has a right to refuse it, but at least you document that you educated them, that they're aware that, you know, they can gain a lot. I've seen people gain 200 pounds on olanzapine in 6 months. 200 pounds. Yeah. It's a lot. EPS. Okay. Try not to use extrapyramidal symptoms once you're practicing and you're documenting notes, all right? Even though we're saying extrapyramidal symptoms here, you want to be very specific. The reason why I'm saying that is because EPS is an umbrella term, and a pet peeve of mine is when I read notes from a patient being transferred to me from another provider, and it says we had to stop medication because of EPS. What does that mean? Was it Parkinsonism? Was it dystonia? Was it tardive dyskinesia? Was it akathisia? Because treatment is different, right? Did they stop your meds because you're having akathisia? Right? Cogentin is not going to work for that. That would be a beta blocker or mirtazapine or a benzo, right? Was it tardive dyskinesia that you stopped it? Because anticholinergic meds will make tardive dyskinesia worse, like we talked about, right? That would be a VMAT inhibitor that would be needed. But if it was acute dystonia, then yes, I can give them Cogentin or Benadryl, right? If it was Parkinsonism, yes, I can give them Cogentin, Benadryl, or amantadine Simitrol. See what I'm going at with this? Even though they're under the same category, the pathophysiology and the treatments are very different. So if you just write EPS, you're not helping the other providers that might be taking over this patient in the future. So be very specific. You can write EPS, but in parentheses, I advise you to write EPS parentheses Parkinsonism. Or write what you're seeing, right? EPS, patient was having stiff joints. EPS, patient was having movements of the mouth, right? And movements of the tongue, which is tardive dyskinesia, all right? EPS, patient couldn't sit still, was walking around the office, couldn't sit down. Akathisia, all right? Or EPS, patient's neck was stuck in one position. Dystonia, all right? Does that make sense? So make sure you know this, very important. This is from dopamine blockade, right? You block dopamine in the nigrostriatal area, you can cause Parkinsonism. Because like I said, you need movement to have smooth movement. You need dopamine to have smooth movement, all right? You block too much dopamine, your muscles are not going to move. You're going to get stiffness, involuntary move. You're going to have stiffness. Your muscles are going to stay there. So if your neck is stuck, we call that torticollis. If my neck is stuck in one way, that's called torticollis. If my eyes are looking up and I can't look down and I can't deviate my vision down, what is that called? Oculogyrocrisis. All right. If all of a sudden they can't breathe and they can't swallow, that's called laryngospasm. That's a medical emergency, right? Patients can die from that. That's the reason why, you know, we have to treat these symptoms right away, because if they get laryngospasm, they're not going to be able to breathe, right? The larynx is going to close up, it's going to tense up, and they can't breathe. Or medical emergency, be careful. They will need IM Benadryl or IM Cogentin. But if they're home, you have to take them right to the emergency room. They need to open up that airway. All right. Akathisia could be dangerous long-term because you have increased suicide risk if you have uncontrolled akathisia. Imagine a patient who can't sit still at night, moving around, they can't relax, they're pacing around the room. There's a high risk of them, you know, jumping out the window, killing themselves because they just want to relieve that anxiety. All right, so be careful. Tardive dyskinesia could be impairing because people will see you moving your mouth. You see homeless people sometimes in the subway, like they're smacking their lips and they're moving their tongue. Be careful with tardive dyskinesia because sometimes it'll be happening with their mouth is closed. So a lot of times I have the patient open their mouth and stick their tongue out like that, because then you'll see the mouth moving. Believe it or not, females tend to report this more than males. You tell me why. Why does a female tend to notice this more than a male? And I'm not being sexist. Makeup, right? When you're doing makeup, you stay in the mirror more, you're doing your makeup, you're doing whatever you're doing, right? Men, you brush your teeth, you walk out, you know, you tend, but females, you're looking at your face when you're brushing your teeth or whatever, usually, and they'll notice that. So I'll usually ask a patient, you know, for a male, when you wash your face or brush your teeth, you ever notice your face moving by itself, right? Females, when you do the same thing and when you're putting on makeup for long periods of time, do you notice anything? All right. Has your partner ever looked at you and said, why are you moving your face like that? Right? Because remember, they're not aware that it's happening. That's one of the differentials of tardive dyskinesia. There's no awareness. So they could be moving their mouth, they could be smacking their lips, they could be moving their tongue. They're not aware of it. They don't know. Someone tells them, what's going on? Why are you doing that? Why are you making that face at me? Right? As opposed to a tic. A tic tends to be rhythmic, right? And they tend to know that it's happening. Tardive dyskinesia, they're not aware it's happening. It's involuntary. All right, and it's non-rhythmic in motion, non-rhythmic. So there's no rhythm to it. It can be fast-paced 1 second. It can happen irregularly. It's very jerky, you know. Any questions with that? Sometimes it's hard to distinguish. People can have both. Someone can have a tic and can have tardive dyskinesia at the same time, right? It's not one or the other. So that's when it gets a little bit more complicated. Usually I'll refer them to a movement disorder specialist, which is a neurologist that specializes just in movement disorders, all right, to really narrow down the diagnosis. Okay, because sometimes, they might have specific treatments for that. Okay, especially patients who have chronic schizophrenia, right? Their dopamine system is all messed up from the long-term medications and possibly from the illness itself, that they might have tardive dyskinesia. And guess what? You can have tardive dyskinesia and stiffness at the same time, right? Believe it or not, you can have both symptoms at the same time. And the challenging part is you can't treat both at the same time because the pathophysiology they're total opposites from each other. So one will worsen while the other one gets better. And you have that difficult question of speaking with the patient and the family, which one is worse, the tardive dyskinesia or the Parkinsonism? Which one is worse, the dystonia or the tardive dyskinesia, right? And you have to kind of balance it out. Very challenging. Yep.
Can you explain that inverse effect again? Like
Yes.
where?
Good. So I'll talk about dystonia first and Parkinsonism. Dystonia and Parkinsonism is due to too much dopamine blockade in the nigrostriatal, like we talked about before, right? Tardive, which means long-term or prolonged dyskinesia, which means involuntary movement, usually happens long-term from long-term use of medication. It's delayed, right? Tardive means delayed, right? You're late, tardive. What happens when you block receptors for too long? I told you guys before, it upregulates, right? It upregulates and becomes more sensitive. So tardive dyskinesia pathophysiology is due to upregulation and increased sensitivity of your dopamine receptors in the nigrostriatal area. So long-term use, you block those dopamine receptors too long, the receptors are going to go up and become more sensitive, right? That's why people tend to develop that later on in treatment. I've seen it early on, but most of the time it's later on in treatment. So in theory, in a general sense, tardive dyskinesia is actually due to a hyperactive dopamine state. Think about what I'm telling you now. Since it's upregulated, increased sensitivity of those receptors, it's almost the same thing as saying you have a hyperactive dopamine state, right? Because every time dopamine touches those postsynaptic receptors, in the striatum, it's going to hyperfire and cause spastic movements, right? Parkinsonism or dystonia is due to a hypoactive dopaminergic state, right? Where there's not enough dopamine. Does that make sense?
Yes. Thank you.
Okay. That's why the treatments are different. Because you give someone anticholinergic medication, you're gonna what? You're gonna increase dopamine, right? Because it's an inverse relationship. But what happens when you increase dopamine and someone has tardive dyskinesia? You're gonna worsen that hyperactive dopamine state because you have upregulated and increased sensitive receptors at the postsynaptic neuron, right? So you say, okay, I'm gonna give you a VMAT inhibitor, which decreases dopamine. So like I said, dystonia and Parkinsonism are due to a low dopaminergic state. You're gonna worsen EPS. See what I'm saying? Where it's kind of like double jeopardy. You can't treat both at the same time. One worsens while the other one gets better. Because either you can increase dopamine or decrease dopamine. You increase dopamine, they become more dyskinetic with tardive. You decrease dopamine, they become worsened with stiffness and Parkinsonism and shakes. Does that make sense?
Yes. But also with TD though, right? It once you have it, it doesn't go away, right?
It
Essentially.
depends. I've had patients that if you catch it early enough, we do an Ames exam, it does go away. If it persists for a long time, then no, it tends to be chronic. Yes. All right. So if it's chronic and you don't catch it right away, it's chronic. It won't go away. If you catch it early enough, it can go away. But well, like I said, sometimes it's so subtle, right, that it's going on for a long time. Like someone's tongue is moving, but it's happening while their mouth is closed, so you don't really see it. Then that's prolonged TD, right? It could be mild when you do an Ames exam, but it's still there. So that could be chronic. It might persist to lip pouting after, then jaw movement, right? Also could go to shoulder movement. Shoulder movement could also be TD also, right? Hip movement could also be TD. So it usually goes from the face to the trunk to the arms. So just be aware of that. Have anyone here seen TD as a nurse in person? Have you seen it in a patient? Yeah, it's bad.
Just like in the mouth, like the tongue.
Yeah, but it can happen in the trunk. I've seen it in the trunk too. There was a patient one time we thought that when I was working inpatient, we thought that the patient was we thought that the patient was sexually preoccupied because they were humping their bed, and we thought they were sexually preoccupied. And then when we called, I wasn't an NP at the time. This was like years ago. And when the psychiatrist came, he was like, no, they're not sexually preoccupied. That's actually tardive dyskinesia. He gave them a VMAT inhibitor, actually went away after about a week or two. All right. So it can happen with the hips, it can happen with the shoulders. So just be careful. All right. Questions? No. Good. Metabolic side effects from atypical antipsychotics. All right. If you want to know a good mnemonic that I usually teach students, FATS, PHATS, mnemonic, FATS for metabolic syndrome. P stands for high blood pressure, right? H stands for low HDL, right? A stands for adipose tissue, right? On the abdomen. So remember, you're not measuring the waist, you're measuring the abdomen, okay? I know we say waist circumference, but it's actually abdomen that you're measuring, okay? T stands for triglycerides. You'll have elevated triglycerides. And S stands for your sugar. Your sugar is going to be high, all right? So if you can't remember this diagram, remember the mnemonic FATS, PHATS. P, blood pressure. H, HDL is going to be low. A, your abdomen fat's going to be high. All right, there's a certain centimeter requirement for males and females. T stands for triglycerides, is going to be elevated. And S stands for sugar, right? Your glucose is going to be elevated. Whether it's fasting blood glucose or your, A1C is going to be elevated, all right? Any questions? Like I said, treatment would be metformin, starting it as soon as you start the atypical antipsychotic, trying to push it up to 2,000 milligrams a day, all right? That's the goal. After long-term metformin use, make sure you check B12 folate levels, all right? Because that can drop. All right. Any questions? Big topic. But like I said, I can't cover everything, but anything you read about that's not clear that I can explain to you.
I had a question actually about benzodiazepines. I read in the book that it said specifically there's a risk for dependence, but they are not addictive. I feel like that's a misconception about benzodiazepines. I feel like a lot of people say that prescribers avoid it because of the addictive properties, but the book said that it was specifically a risk for dependence, but not addictive. Is that true?
Which book did that come from?
That was the Ettinger book.
That's not
Yeah,
true.
in the psychopharmacology book. I also was like, I'm not sure if that's accurate,
But
but
don't worry about that. I mean, that's controversial, but I'm not going to ask you that question specifically on the test. Don't worry about it. Yeah.
Okay.
But, we'd rather, side on caution. So, obviously benzo dependence and addictiveness can be, addiction is a very when we talk about addictions, it's a very complex process, the physical and of course the psychological dependence or addiction to stuff. But, I prescribe benzos. I think people who don't prescribe benzos are doing their patients a disservice because it could be life-changing. I mean, anything in psychiatry can be prescribed as long as the prescriber is, aware of what the risks are and monitors appropriately. So I'm not against benzos. I do know some people who practice and definitely know they don't even take patients if they're on a benzo. But I don't believe that, because as long as you're prescribing it appropriately and you're monitoring appropriately, especially someone who has panic attacks, right? They need it. They can't function without it. They don't drink alcohol. They never run out of medications early. Unfortunately, it should be used, sparingly, obviously, but.
Thank you.
I tend whenever someone tells me that their preceptor tells them never to do this or never do that, I tend to say, well, in psych, there's never really black and white sometimes. If you know the fundamentals of how psychopharmacology works, there's really never yes or no answers. There's kind of a lot of gray areas, and it's up to you as a professional to understand when the situation is right for a patient to use it. Because anything could be dangerous, right? You give a scissor to a 2-year-old, they could do a lot of damage with it.
somewhere with the anxiety meds and then also the mood disorder meds, I guess, is Buspar, but I was kind of confused. It's for anxiety, but it's not necessarily an antidepressant. So I guess I'm
Yes,
just
good question.
speak more to that.
Very good. So Buspar was created, and the name actually stands for sparing, like abuse, abuse, Buspar, BUS. Spar means sparing. So abuse sparing, that was the name actually. That's what they called it, Buspar. They thought it was going to be a great medication as an alternate to benzos, but they were wrong, unfortunately. The problem with Buspar is that it's used a lot in inpatient. And I'm guilty of using Buspar a lot when I was inpatient. The problem with Buspar is a very short half-life, and it tends to work better with its TID dosing, right? So what happens is patients will do very well on it inpatient. Then when they go to be outpatient, to take a medication 3 times a day, the more times you dose it, it's very difficult, right? And Buspar is not that great as an antidepressant because it's only a 5-HT1A partial agonist, right? It's not an SSRI. So it might not be giving enough serotonergic, and it's only hitting that one receptor to really help as much. So it is a good adjunct, and I have seen people use it early on. So remember, like I told you guys in the first 2 lectures, was that it's downregulation of the 5-HT1A autoreceptor, the presynaptic neuron, that takes time for the antidepressant properties to work, right? Remember I mentioned that? So how can you speed up that downregulation of the receptor? By giving someone a 5-HT1A partial agonist on top of an SSRI. Because they're getting that serotonergic property that's going to hit it, right, when you increase serotonin by blocking SERT. But at the same time, you're giving them a direct 5-HT1A partial agonist like Buspar to downregulate that receptor even faster. So there are some studies that show that. And I have seen anecdotally with patients too, that if you give them Buspar, maybe for the first month of treatment, it might increase the response time to SSRIs. And you'll see that sometimes, right? You'll be on Searchling with Buspar. And they'll usually do it inpatient because, the nurse can give it to them 3 times a day and they're taking it. But we usually wean them off because it's not a practical regimen once they're out, I'm going to say something controversial, but it's okay. I don't care because I believe it. Real psychiatry happens outpatient. Think about that for a second. Real psychiatry happens outpatient because inpatient, insurance companies only pay for a 2-week stay, right? So inpatient doctors will be like, well, we need to get you out in a week. They'll put them on 3 or 4 medications, 3 times a day dosing, right? You'll be on risperidone twice a day, right? Cogentin twice a day. You might have hydroxyzine PRN as needed, right? For sleep and anxiety. and you might be on like other medications just in case also. How are they going to continue that outpatient, right? That's not feasible. So it's out to outpatient to put you on a regimen that you're going to be taking for the rest of your life, right? If you truly need it for the rest of your life. So that's why I think as a practitioner, if you guys can get a good job as an outpatient provider, it'll do you wonders because you'll know how to manage every type of medication and you'll know the practical sense of because the thing is you won't even know if the meds are doing well for a patient, right? Because it takes about if it takes 3 to 4 weeks for an SSRI to really work and you're working inpatient and you're starting everyone on Zoloft and they get discharged in 2 weeks, how do you know if Zoloft's really working? Right? It's not really. So I'm sorry if anyone aspires here to work in patient psychiatry. I'm not discouraging you, but I'm just letting you know that I think that psychiatry really is done in outpatient. Because I have patients right now, I've been practicing for 5 years, they've been with me for 5 years. And I'll tell you what, if I stayed in the same clinic and I stayed there for 20 years, they'll probably be with me for 20 years. So imagine me managing their meds as a teenager all the way until a middle adult or even geriatric, right? That's when you really know psychopharmacology because you're managing them through the whole lifespan, right? And that's the key.
I have a question with metformin. Like you said, it's better off to start them right away once they start taking an antipsychotic. Like if they already gained weight while they've been on the antipsychotic, it won't really make a difference.
That's not.
So like I have this patient on my unit who has gained like a significant amount of weight and she's on like Prolixin twice a day, Clozaril at night. She like binge eats like every meal and like they know that she's gained all this weight and she's not on metformin. So like what would you do for someone like that? Could you put them like on Topamax to like curb their appetite? Like would that make a difference?
I've done that strategy too. I've used topiramate also. The only thing about topiramate, it can cause cognitive dulling. So it can cause patients to be confused. It also can cause renal stones. There's a bunch of complications with Topamax. But I think how many pounds did she gain on the clozapine? 100 pounds?
In the past, well, over the past month, I think like 25 pounds.
Maybe consult with endocrinologist and try to get her on Ozempic. I mean, we've done that because you're not going to lose that, you know. Binge eating disorder can also be controlled with, you know, behavioral and lisdexamfetamine, Vyvanse, right? But the problem is you're giving someone who's psychotic a stimulant. And, you know, if they miss a few doses of clozapine, they can become more psychotic, right? So it's
Yeah,
kind of like,
no, she wouldn't be able to handle it. She has like schizophrenia, bipolar type. She can't, so she would be off the
once
wall.
patients reach the end of the road, and it's like clozapine is like the end of the road treatment, it's our best treatment, and we tend to reserve because so I specialize in schizophrenia, so I have many patients on clozapine. So, you know, I tend to see a lot of that metabolic side effects. And it's a tough act because if they can't tolerate the metabolic symptoms of clozapine, there's nothing else to go to. So I usually partner, there's an endocrinologist that I know that has a good practice in Queens that I partner with because they're aware that clozapine is the last treatment for this patient. So they'll give them all the options that they need to try to stay on the clozapine. Because what happens if you partner with another specialist who's not aware of the psych meds, they'll say, oh, easy, stop clozapine, right? That's the reason why you gain so much weight, stop clozapine, right? But they're not aware that clozapine is the last stop for this patient. And if you stop clozapine and you re-challenge them, it may not work for them again. So, you know, you need to find, you know, I'll just say psych-friendly specialists, and there's not many of them. Right? So it's your job to advocate for your patient to make sure that they stay on the medications and you manage them accordingly. Yeah, I would do a consult with endocrinology to see if you can find any other ways. How old are they?
She's like 26 years old.
Oh, wow, she's young. Okay.
Yeah.
She's young, so that's good. But the bad news is, you know, well, the reason why it's good news that she's young is that I'm pretty hopeful that in the next 10 years that new mechanisms will come out that may take clozapine's place, right? So she might be able to, if she was like 60 or 70, you know, it's going to be tougher. But there's a new class of medication. This is just, you know, for your information, cholinergic agonists and TAR1 agonists, which are about to become FDA approved. They're in phase 3 now. And hopefully they come out in September. That's the plan. I'm going to offer them to my patients too. So they're the first class of meds that don't rely on dopamine blockade for antipsychotic effect, right? If you come to me next semester and we do clinicals together, or you're in my other class, 527 or 517, we can talk about it. But I don't want to confuse you guys now. Just get the fundamentals down first. I also put a video up. If you guys saw the schizophrenia lecture, those students are 547 students that are in that. Did you guys watch it? Anyone watch that lecture yet on schizophrenia? No, it's on my YouTube channel. But that's a lecture I did for the 547 students who will be graduating in like 2 months. So they asked pretty good questions, and you know, we cover much more specific details in that lectures if you want to watch it. It's on my YouTube channel.
Professor,
Yeah.
so you mentioned about the clinicals, correct? I wonder if you know, I believe today is the due date to submit the form for the clinicals, March 1st. I've been reading the whole thing in the website, but I couldn't find where I'm supposed to submit the clinical, the person that I'm gonna work with. So do you know where I can find that for the clinicals?
You know what? Send an email to Professor Smith because he's on faculty. Yeah.
Yeah, I already did, but he didn't answer.
There's a email link that they send you that you fill the form out.
Yeah.
It's a generated one from, oh my God, what is his name? But it's a drop down box where you fill everything out and send it in, and it's due on the 15th now, not the 1st.
Oh,
Ken McDowell sent another email for March 15th. So
can you do me a big favor? Can you send it to me? I can send my email to you, and if you don't mind, Moscow.
No, not at all.
I'm gonna send you the email my email right now. And Professor, I have another question about Buspar. So I'm working on the case study, and I was thinking to, to talk about Buspar. I believe it's the only medication FDA approved for treatment of anxiety in the United States. And
no, I don't think that's accurate. No, it's definitely not the only. It's not the only. It's one of them.
The only type of Spari that you were talking about for anxiety. That's what I read.
Yeah, Spari. Yeah, Spari. If you just want to say Spari, yeah.
But the first line of treatment is CBT and SSRIs, right?
That's true. Yes.
So I just wonder if we already know that, should we, in real life, if I'm talking to somebody who never been in medication, and this person doesn't want to have the side effects like sexual dysfunction due to SSRIs, and if I want to prescribe the Buspar, that's a good practice, or I have to prescribe SSRIs first? Like, I don't know, Prozac, Lexapro.
From a practical standpoint, Buspar is not a realistic regimen, like I said, because it's 3 times a day dosing. So if a patient is willing to take a med 3 times a day, then sure, but you should educate them that that's a downside to it. If they're willing to take a med 3 times a day, then yes, it might be. Might be, yeah.
Okay.
Yeah.
Thank you.
Sure. All right, hold on 1 second.